Today we're going to be talking about pulmonary hypertension. Now, pulmonary hypertension is defined in your book as a pulmonary artery pressure that is greater than 25 millimeters at rest and 30 millimeters of mercury with exercise. So this is due to an increased resistance in the blood flow through that pulmonary circulation. Normally, pulmonary circulation is characterized by low resistance and low pressure. But with pulmonary hypertension, what's going to happen is we're going to have increased resistance because that right side of the heart is going to have to pump harder to try to get volume into that pulmonary artery because that pressure is so much higher. So what's going to happen is over time, those elevated pulmonary pressures are going to cause some structural damage within the lung. Now remember, the blood that's flowing from the right side of the heart into the lungs is referred to as pulmonary circulation. And the blood that is flowing from the left side of the heart out into the body, that is referred to as systemic circulation. So I just want to make sure that you understand the difference between that. So this eventually can lead to right-sided heart failure. And if these patients aren't treated, then what's going to happen is they can die within 2 years of having pulmonary hypertension. And the issue with pulmonary hypertension is that it's usually not evident until later on in its progression. And by that time, a lot of the damage has been done and it's advanced. And so there's not much that we can really do to help these patients. And the bottom line is it leads to poor perfusion and hypoxemia. There's two types of pulmonary hypertension. One of them is called primary or idiopathic, and idiopathic means I really don't know what's causing this. So the real cause they don't know. It's been associated with maybe some cirrhosis, connective tissue diseases, those types of things. But it's one of the things they really think about or they're feeling is that there is some abnormality within the endothelial cells that line the arteries within that pulmonary system. And so that abnormality is happening because of, they may not know if it's primary or secondary. It's going to happen secondary to a disease process. They also feel that there is some genetic predisposition to people developing pulmonary hypertension. So again, secondary hypertension, that tends to be a little more common than your primary or idiopathic hypertension, and this is usually the result of problems or other disease processes. And one of the main ones that is a problem or you see that happens or causes this is COPD. So that's the most common cause of secondary pulmonary hypertension. And again, the end result, whether it's a primary hypertension or a secondary hypertension, is the damage that's going on within those lungs. And the end result, again, is the hypoxemia that this patient has. So pathophysiology, your book has a very, very basic pathophysiology map, and that's fine. We don't need to get real in depth in the pathophysiology of pulmonary hypertension, but when you're talking about the pulmonary arteries themselves, the normal pulmonary arteries have less smooth muscle than systemic arteries have. So they're very thin-walled and they're distensible. And what that means is that these pulmonary arteries can dilate and accept large volumes of blood based on what's going on. So for instance, if you're out there and you're running that 26-mile marathon, that pulmonary system is going to need a lot more blood because you have a greater demand for oxygen when you're exercising like that. So what's going to happen then is that in patients with pulmonary artery hypertension, there is some insult that happens that's going to start this whole inflammatory response and cause injury to that pulmonary endothelial lining. So it can be a hormonal, mechanical, there's many different theories as to what can actually cause this. So over time, those smooth muscles proliferate in the intima, which is the innermost layer of the vessel. And it's going to make those pulmonary arterial walls thicker. That thickening or remodeling, so that thickening or remodeling is irreversible. And because it's thickening, it's narrowing the size of that blood vessel. So it's basically causing a permanent vasoconstriction. So what the entire pulmonary vascular bed then is going to be destroyed or obstructed. And since we've lost that ability to distend, what's happening now is these pulmonary vessels aren't able to handle this blood volume that is coming to them. And over time, you're going to get that vascular remodeling, which is what's happening right here when those cells proliferate and the walls get thicker. We have this vascular remodeling going on. And again, as I said, that vascular remodeling that's happening is irreversible. And so the pulmonary vessels so we have that smooth muscle proliferation. That's what they call it according to your book. And we get this scarring or this remodeling that's happening within the lung. The other thing that's going to happen then, once we get that scarring and remodeling, etc., our pulmonary pressures are going to increase, which increases our resistance. So the right ventricle enlarges as it tries to overcome these abnormally high pulmonary artery pressures. And what's going to happen is if that right ventricle can't overcome that pressure, the pressure is going to increase in that right side of the heart because it's going to backflow, and it's also going to go into systemic venous circulation, and the patient is going to present with symptoms of right-sided heart failure like ascites, hepatomegaly, etc. So that's sort of what's going on partly. And then the other thing that happens is the progression of this pulmonary artery hypertension also predisposes this patient to pulmonary thrombus and embolism. So besides an increase in pulmonary arterial resistance to forward blood flow, what's happening is there's substances that are being released because of this insult that cause platelet aggregation. So again, we have lots of things going on in this lung. The pulmonary bed is destroyed or obstructed. There's scarring, that smooth muscle layer, those cells in that smooth muscle proliferate in the innermost portion of that vessel wall, making that wall thicker. So you almost get this vasoconstriction or narrowing of those vessels, which will also cause the increased pressure within that pulmonary system. So that's basically what's going on with this patient. They sometimes refer to this enlargement of the right side of the heart as COR, C-O-R, pulmonale, P-U-L-M-O-N-A-L-E. So that's basically very basic pathophysiology for pulmonary hypertension. So what kinds of signs and symptoms are we going to see with this patient? Well, again, think about this patient who has destruction of the pulmonary vascular bed. Think of this patient who has a much narrower pulmonary arterial system, so there's less blood flow. So one of the classic symptoms of pulmonary hypertension is dyspnea. And the dyspnea is the most common initial symptom, and it occurs at rest and upon exertion. So they have dyspnea at rest and also exertional dyspnea. And those are usually related to that reduced cardiac output because we're just not getting enough volume into the lungs to be able to transport out into the body oxygenation or oxygenated blood. Other things that you're going to see are exertional intolerance, which is basically anytime you exert yourself, and you increase your activity, etc., or you will find that you're short of breath. Exertional chest pain, because what's happening, right, is I'm not getting as much oxygenated blood to the left side of the heart. Hence, I have less oxygenated blood in systemic circulation. So chest pain, dizziness, syncope, these are all related to inability or decreased cardiac output in response to increased oxygen demand. So these are some of the things that you may see in these patients. And again, you'll see some signs and symptoms of right-sided heart failure. So these are basically the cor pulmonale, or the right-sided heart failure. So this acute strain on that right ventricle caused by these changes in these pulmonary vessels in the lungs lead to that right-sided heart failure. And so what's going to happen then is the person is going to present not only with respiratory symptoms because of oxygenation issues, but also they're going to present with these signs and symptoms of right-sided heart failure. And you're aware of symptoms of right-sided heart failure, so I'm not going to go through all this. But again, this is something that you need to assess in your patients. So what do we do from a diagnostic testing standpoint? On the average, patients with pulmonary hypertension, according to the literature, aren't diagnosed until about 2 years after the onset of symptoms. And the problem is, by then, that significant damage has already occurred within those pulmonary arteries, right? So we have the thickening, we have the narrowing, right? We have that vascular bed being obstructed and destroyed. And we also have the potential for thrombus and pulmonary embolism. So what they may do is a chest x-ray, and that chest x-ray may reveal enlargement of the right ventricle. It may show some shadows within that pulmonary system, and they may look at an EKG, and the EKG may show right ventricular hypertrophy. And so those are some things that may give them the diagnosis that we need to look at something going on potentially in those lungs, because I'm having a problem here with the right side of my heart. All right. Pulmonary function test, of course, makes sense. They would do these pulmonary function tests because they want to look at, patients' tidal volumes, those kinds of things. Ventilation perfusion scan. We just talked about that with respiratory. So we're looking at the ventilation piece and the perfusion piece. So we're trying to figure out, is the problem with the ventilation, right, which is within that alveoli, or is there a problem with the perfusion, which is that pulmonary capillary membrane portion of it? Arterial blood gases, correct, are just going to let us look at the acid-base balance within this patient, where the problem maybe lies. Echocardiograms, you understand those. Those look at the structure of the heart, the size of the heart, the wall motion, ejection fractions, things like that. They may do a right-sided heart catheterization, and this is the definitive diagnostic study of choice to determine the extent of the pulmonary hypertension. Because when they do a right-sided cardiac cath, this study can directly measure those pulmonary artery pressures. It can measure cardiac output. They can measure pulmonary vascular resistance, which is PVR. And they can also measure through this right-sided heart cath the pulmonary capillary wedge pressure, or that pulmonary arterial occlusion pressure that we talked about with hemodynamics. So in healthy adults, the PA pressures and the pulmonary capillary wedge pressures, aren't elevated, but in these patients, they would be elevated. So that's kind of the test that they use as the quote unquote definitive test to see if this patient actually has pulmonary hypertension. So how do we treat these patients? Well, although there's no cure for pulmonary hypertension, our goal is just treatment to relieve the symptoms. So it's symptomatic treatment basically, to try to increase the quality of life and also to try to prolong life. So there's things that we need to look at that we can do, and your book does list in a table some of the different medications that they use for patients that have pulmonary hypertension. It's just a table that talks about different drug therapies. But again, the goal is to try to slow down the progression of the disease if we can do that. And remember, what can happen then is they can also get those blood clots. So we may have to give them some anticoagulation therapy for patients with severe pulmonary hypertension to prevent these microthrombi from occurring within the pulmonary vascular system. And we also have to look at ways to try to reduce that vasoconstriction, to try to open up those blood vessels if we can, in order to increase blood flow. So some of the medications that we talk about with pulmonary artery hypertension, there's different types of medications. Some of them, and one of them that your book actually talks about, are vasodilators, and these are given parenterally. And these are the cornerstone of pharmacological management. So basically what that means is these are the drugs that they give to these patients. And so these drugs are given intravenously via a central line is the best way to give these medications. And what these vasodilators do, and I've listed a couple of them, the Flolan and the Remodulin, what these actually do is they help to open up the pulmonary arterial system and reduce that resistance within the vascular system. So the Flolan is a vasodilator, and it's a very potent vasodilator, and it dilates systemic and pulmonary vasculature. The problem with this medication is it has a very short half-life, and it has to be given by continuous infusion. And so again, that medication may not be the first line because it has to be given by continuous infusion. The Remodulin has a longer half-life, and it can be administered subcutaneous infusion through a pump 24 hours a day. And so again, there's different classes of pulmonary hypertension, but I'm not going to get into all of those. But Flolan is a very expensive drug. I don't know how much the cost has gone up now, but when I did some research in the past, it was about $100,000 or more a year. And so what they do with these meds is there's other meds out there called calcium channel blockers that you're aware of, right? And we'll talk about those in a second. But they usually try calcium channel blockers on these patients first because it dilates the smooth muscle. So they will try calcium channel blockers, and if those don't work and patients don't respond to calcium channel blockers, then they'll try to give them these vasodilators. So if I can give them these vasodilators, then what happens, it reduces that right ventricular pressure and overload, because we open up those blood vessels, and hopefully the other thing that it does is help prevent further damage to that pulmonary vascular system. Another classification of medications that are used are your phosphodiesterase inhibitors. And again, those medications, there's a couple of them that I listed there. And so what they do again is they promote relaxation of the smooth muscle within the vessels within the lungs. And these can be given orally, which is good. And so again, I can't say what medication is better than another medication, but these are just meds that we can try to give to these patients. Endothelial receptor antagonists are another medication that your book talks about that we can give to these patients. And what that does is it binds to receptors within that pulmonary vascular system to decrease that pulmonary artery pressure and that pulmonary artery resistance. So what it's doing is it's sort of relaxing the pulmonary arteries and thereby decreasing those pulmonary artery pressures. So this is good because it can be given orally, which is nice. But the problem with this medication is it is hepatotoxic, and so that becomes a problem. So we need to, patients will need baseline liver function tests, and some evidence-based practice states that when they're on these meds like your Tracleer, that they should have monthly liver function tests just to monitor them, and that if the person ends up showing elevated liver enzymes, then we would have to stop these medications. So that's just information on those types of medications. The calcium channel blockers we already talked about, like nifedipine or Procardia, diltiazem or cardizem or amlodipine or Norvasc. As I said, these are often first-line agents to treat pulmonary hypertension. And of course, if they don't respond to the calcium channel blockers, then they will try the vasodilator medications. So those are some of the medications we can use on these patients. Other medications are diuretics, and diuretic therapy basically is to, again, it's symptom relief. So it will help try to relieve some of the respiratory problems the patient is having and some of the edema that they're having. And if we can get rid of some of this fluid, then we can hopefully reduce that right ventricular volume overload. So anticoagulation therapy is also recommended for these patients because remember we talked about the potential of getting blood clots, and also not only blood clots in the lungs, but we also have to think about venous thrombosis due to the backflow of the blood from the right ventricle back into the venous system because of that high pressure within that pulmonary system. Ionotropes are reserved for the patient with heart failure. You already know ionotropes increase contractility. So then in the end, what we have to think about in these patients is actually a lung transplant. This is reserved for advanced pulmonary hypertension for patients who are not responsive to the normal medical therapy. I don't have the criteria for lung transplants, but it may involve just a single lung or an entire lung transplant. And so if the cor pulmonale or right-sided heart failure is present, many times these patients will need both a heart and lung transplant. And you know how difficult it is to be able to get organ transplants. So the other thing is according to the literature, it's not known whether the process of this pulmonary vasoconstriction and, you know, the thickening of those walls can begin in a transplanted lung, or if having this transplanted lung is actually a cure. So they do not know the answer to that question. Nursing assessment, again, when I'm looking at nursing assessment, what I'm just going to say to you is a lot of this is looking at signs of respiratory distress and looking at signs of decreased cardiac output and heart failure. So we need to monitor respiratory symptoms, cardiac symptoms, and with oxygenation, our goal here is to try to keep that O2 sat greater than 90%. And 90% is probably excellent on somebody that has that pulmonary remodeling going on in their lungs. So again, you need to think about these different types of things when you're taking care of these patients. So again, think about, how do you treat somebody that has respiratory issues? How do you treat somebody who has heart failure? What do you do from a nursing standpoint with these patients? And that's the type of thing that you're going to have to look at when you're taking care of and assessing patients with pulmonary hypertension.